Hey everyone, we're going to go over some clinical sim practice tonight. We're going to work on the adult side of the world and talk about a skydiver that got hurt in a skydiving accident. He's 33 years old and he is in the trauma ICU. So trauma ICU always has a lot of really neat backstories, and it's fun to work if you like to see some different things. They always have if you're working in a good hospital with a lot of great equipment, you can learn so much, just years, layers of things to learn in the trauma ICU. So the basic knowledge that we need to know, though, is how to work with a trauma patient that is developing some hemodynamic issues, and that's what we're going to talk about tonight. So he's 33 years old. He's a skydiver. It's asking us to evaluate him, and his cardiac output is our first hemodynamic issue we're going to look at. It's 6.2, so that's okay. We know that 4 to 8 is normal. Of course, that is just according to what book you're looking at, okay? So some of them, may vary by a couple points on each end. So don't be discouraged about that, but we're going to go with 4 to 8 for this sim is normal. Pulmonary capillary wedge pressure is 6, which is okay. His normal would be a range of 4 to 12. His PAP is 29/16, so that's a little bit elevated. His CVP is 10, so his central venous pressure, and that tells us what kind of blood volume that he has, and that can be, as you know, affected by some different things like the dilation of his arteries and pressure and function in the right ventricle. And so we're measuring it there at the vena cava, and so his pressure is 10. We like to stay less than 8, so that's a little bit elevated. His blood pressure is 140/86 based on a normal of 120/80, so it's a little bit elevated. His CaVO2 difference is 4.7. Normal is 5, so that's not bad. Pulmonary shunt is 21%. We know that anything less than 10 is really good. Anything greater than 30 is super bad, so we need to try to get it back down closer to 10. Right now it's showing at 21. We've got him, we've pulled the blood gas, and it's telling us that his pH is 7.36, which is within normal range for now. His PCO2 is 37, so that's telling us that he's ventilating okay. His PO2 is only 53 though, and his saturation's 84%. So we've definitely got an oxygenation problem. His hemodynamics overall don't look too bad, but we've got to figure out how to oxygenate him and not affect those hemodynamics any more than we absolutely have to. So we're going to recommend that he's on volume control SIV with an FiO2 of 100%. His breath rate is set on 12. His tidal volume is set at 450. He's got it on a PEEP of 10. His peak inspiratory pressure is 32 with a plateau pressure of 19. So the doctor is going to ask us, what do you want to do? What do you recommend to help with this oxygenation issue? So we're going to recommend, even though he's on a PEEP of 10, we're going to recommend that we increase that by 5 and go ahead and bump up to 15 of PEEP. Don't be afraid to use your PEEP settings to help recruit those alveoli that are kind of have lost their form and are just kind of being lazy, not doing their job. So we bump him up to 15, but it has little effect. So we want to think about increasing the PEEP, but we're really concerned and we're having to keep a close eye on the hemodynamics. So also we choose to do our own assessment now. We're looking at an x-ray that's showing us a tracheal shift to the left. So we know that there's something going on. We've got to find out what it is. If it's outside the lung, it's going to push the trachea away from the whatever's affecting the shift, and then if it's inside the lung, it's going to pull the trachea toward the affected side. So we have a hyperresonant percussion note on the right, unilateral breath sounds. So we've got something different on the left than from the right. Our x-ray is showing us a right side pneumothorax. We go ahead and insert a chest tube to correct that, and 2 hours later we pull another ABG. Now this, I will just warn you, this is one of the longer, more in-depth SIMs that is available on the practice site. So that's what this information is based on that we're talking about tonight. So just bear with me. You want to be prepared to do these kind of tiring, long SIMs and be able to look at the hemodynamics and look at all of your lab work and your x-ray in order to help this patient. We are working in the trauma unit, and a lot of times those patients do require a lot of focus. So we pull an ABG, and our pH is 7.37, which is still within acceptable range of 7.35 to 7.45. Our PCO2 is 41, so he's ventilating okay. Our PO2 is 45 though, so he's still not oxygenating well. He has a bicarb of -22, and his site's only 77%. Now keep in mind that he is on 15 of PEEP the last time they gave us a number. So we check his cardiac output, and it is 6.1. Normal is 4 to 8. His pulmonary capillary wedge pressure is 8. Normal is 4 to 12, so we're okay there. Our PAP is 40/24, so that's a little high. Our CVP is 8. Anything 8 or below is good, so we're okay there. Our blood pressure is 144/88, so he's a little hypertensive. Normal is 120/80, but he's got a lot of issues going on. Our CaVO2 is 5. Normal is 5, so we're okay there. Shunt is 24%. Anything less than 10 is good. Anything greater than 30 is unacceptable, so we're at 24. We want to do better and get down closer to 10, but for right now that's as good as it gets. So our peak inspiratory pressure is 39, so our plateau pressure is 27. So there's only, what are we looking at, 12 points different between our PEEP and our plateau. We're going to go ahead and change our PEEP on up to 25 centimeters of water because the hypoxia is getting worse. And remember, it's okay to use the PEEP because our hemodynamics are not too bad out of range. Some of them are not out of range at all. Our vent pressures are rising though, so we know the lungs are getting less compliant. Metabolic acidosis is kind of kicking in, and still not improving as quickly as we would like, or as much as we would like as far as oxygenation goes. Our cardiac output is now 3.4. So remember, normal for cardiac output is 4 to 12. So our pulmonary capillary wedge pressure is now 14. Our normal is 4 to 12 on that. So, I'm sorry, our normal cardiac output is not, did I say 4 to 12? I'm so sorry. Our normal cardiac output is 4 to 8. So our normal capillary wedge pressure is 4 to 12. Our PAP is 48/34. It's continuing to bump up. Our CVP is 20. We need to be less than 8. Our blood pressure is 74/46. So we took quite a dip there. Our CaVO2 is 8.2. Our shunt percent is now climbed up to 34%. It's becoming more serious. We need to be less than 10. Anything over 30 is definitely serious. Our peak inspiratory pressure is now 51, and our plateau pressure is 38. So we're going to go ahead and adjust our PEEP down to 20 because we've got some effect on the hemodynamics that we really don't want to continue with. We're going to set the FiO2 now at 100%. And while the hemodynamics are getting worse, the airway pressures are elevated, the increase in the PEEP is definitely affecting our cardiac output. It has dropped, our shunt is increased, and our CaVO2 is widening. So this is beyond optimal PEEP, so we've got to decrease that and then try to increase the FiO2 to make up for it. Some recommendations that we can offer for this patient would be to try a high-frequency oscillating ventilation with, tiny volumes and fast rate. An inverse IE ratio where we try to prolong inspiratory time in order to improve oxygenation. And pressure control ventilation, since he has hit the 51 mark with his peak inspiratory pressure, we could change him over to pressure control, but we've got to make sure that he's still getting adequate tidal volumes. So we may have to choose permissive hypercapnia because we want to protect him from barrel trauma. So the decrease in tidal volume that may result by changing to pressure control ventilation may allow his PCO2 to creep up, but we've got to allow that right now because we're kind of in a quandary with all the oxygenation and refractory hypoxemia he has going on, and we're trying to balance his hemodynamics with that. So that's where this sim ends, is with our recommendations to try either the high frequency, the bivent or inverse ratio ventilation, try pressure control, or allow some permissive hypercapnia. So this is a very complicated patient. He's going to be really blessed to survive, obviously, and everything is really a challenge for the team. So in talking about hemodynamics, you want to make sure that the cardiac output is very important, and that's made up of your your heart rate multiplied by your stroke volume, as you remember. So how much is in the atrium that's going to be able to be the preload to the ventricle, and we need to have that calculated out. We need to keep an eye on it and watch the trends when we're using therapeutic PEEP levels, especially when you get up to 20 and 25, and I've even seen 30 used before. So the strength and the rate of the contraction is very important when it comes to cardiac output, and it affects that level. And so we want to have enough cardiac output there for the tissues to be oxygenated, but it has to be available for the heart to be able to pump it out. So if we insert Swan-Ganz, we're going to be able to measure the pulmonary capillary wedge pressure, where we inflate the balloon as it floats into the arterial branch of the small arterioles and wedges there to give us that reading. And it's indirect left atrial pressure measurement, and it is the most accurate reflection of preload. So the CVP is increased when there's an increased blood volume, or the arteries are really dilated, or there's a decreased right ventricular function, so it's not being pumped out, and so it ends up increasing the CVP. And then the pressure in the vena cava near the right atrium is where the CVP is measured. So we want to go ahead and make sure that you've got all your normals down. Just one more reminder: PAP normal 20-30, CVP less than 8, pulmonary capillary wedge pressure 4 to 12, shunt less than 10%. Greater than 30 is definitely serious. Our cardiac output is normal is 4 to 8. Our stroke volume 60 to 120. And we want to make sure that we understand that when these are all increased, then we have cardiac pulmonary edema, cardiogenic pulmonary edema. When there's ARDS involved in the lungs, there's pulmonary edema involved there because of lack of compliance and refractory hypoxemia, then that would be considered non-cardiogenic. It's not the heart issue that's really causing the pulmonary edema. It's the lack of the compliance of the lungs and then the backup of that fluid into the alveoli. So we've got to be familiar with all of our hemodynamics, and then we've got to keep our ventilation, oxygenation, circulation, and perfusion our priorities. We've got to keep those in line, and we've got to make sure they're all working together to maintain balance and homeostasis and to help our patient to recover as soon as possible. So, well, thanks for listening. I know that was a long one, and it's a little bit much, but when you get into the hemodynamics and you start working into the trauma ICU, there's hardly ever a simple case. So definitely leave a comment or message if you have any questions. We'll find the answer for you and make sure you understand what you need to get through these SIMs. Thanks a bunch for listening.